The regulations and the guidelines create a burden and an expectation level upon the healthcare practitioner. And that's where this all comes into play. It's like drug products liability law, which used to be essentially, as it related to the drug company, an issue of warning, and a doctor was entitled to a defense that he was a learned intermediary, and if the warning was adequate and he could establish that he provided that warning, the doctor could be defended. Well, now you see that there are ads on television which say that for various drugs, especially on the network news at night, and the end of the commercial will say, among other things, ask your pharmacist. So now the pharmacist, the pharmacy has been dragged into that, and the law is changing. Language barriers between the healthcare practitioner and the parent or the guardian. It's very common, especially in a city hospital or in a clinic or something, that the parent and the healthcare provider really do not speak the same language. And that's a problem. Uneducated parent or guardian. It's very clear, and especially for those of us who grew up in the medical malpractice world, it's very clear that when a doctor is telling a parent something, especially something a parent doesn't want to hear, in large measure, it might go in one ear and out the other, or it might not ever be retained by that parent. So the uneducated parent or guardian is a problem as it relates to the delivery of effective anticipatory guidance. And then, of course, you have time constraints. I mean, I don't know what the time constraint is of the average doctor in a city clinic, but I would guess that they have more people to see each day than there are hours in the day. And so, the patient may tend to get short-shrifted, and so that's a problem. And then you have the doctor who has a problem in terms of record keeping because the doctor is overwhelmed, and how much time can you sit and create notes that might be effective 5 or 10 or more years up the road if, in fact, the doctor ends up in litigation. How do you defend these situations? Well, the first one is proper record keeping. And I suggest the creation of a standard form which could be used that has check marks and boxes that a healthcare practitioner could check off, and therefore at least be able to say that even though nobody remembers any of this stuff, because it happened however many months, weeks, years, decades earlier, because I checked this box and this box and this box, that means I told the mother this, 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 and this. Effective communication between mom or the guardian and the healthcare provider. The use of translators, multilingual, multi-language literature. And then the development by the healthcare practitioner of an invariable custom and practice. That is, this is what I do on every single case. This is what I do every single day. This is what I do 35 times a day. Although I don't remember this incident, although I don't remember this family, I don't remember this child, I don't remember telling this mother, I do this on every single time, regardless of whatever the situation is. And if they're screaming at me outside to go see 5 more patients, I'm going to tell this mother exactly what needs to be told. If the doctor can say that and be credible in the subject, then that goes a long way towards defending. Well, there's kind of a lack of common interest between the medical malpractice carriers and the general liability carriers. In New York State, there are very few carriers that write medical malpractice. Medical Liability Mutual, the Medical Malpractice Liability Insurance Company, Physicians Reciprocal, maybe a few others. But in large measure, the general liability carriers do not write, and the big insurance companies do not write medical malpractice insurance coverage. As a result of that, there's kind of a lack of feeling as between the two. The medical malpractice insurance policies invariably contain consent requirements which require the doctor or the hospital to consent to a settlement. And as a result of that, I think that those cases, I know that those cases are more difficult to settle because the doctor or the hospital will not consent. So where you have the general liability insurance carrier, or if you have an uninsured landlord who's got resources and therefore exposure, who would like to try to settle with the plaintiff's lawyer, sometimes it's impossible to settle with the medical malpractice component because they don't want to or they can't get the consent of the doctor or the hospital. And I don't know about other places, but in New York, about 75% of all medical malpractice trials result in a defense verdict, and that's, of course, a much higher percentage than in other types of trials, so that doesn't exactly lend itself to an easy resolution. It's pretty simple. You need a pediatrician, and you need a pediatrician who can testify to the standard of care in that community for the giving of anticipatory guidance, for the screening, and for the risk assessment of a child similarly situated to little Johnny, who's the ostensible plaintiff in that case.